Hello, everyone, and welcome to this presentation. My name is Jeff Schneider. I'm a physiotherapist, epidemiologist, and clinical researcher at Evidence Sport and Spine. It's my pleasure to present on this topic today, near and dear to my heart for sure, and many clinicians that manage patients with acute low back pain. At Evidence North, we started this program around 8 or 9 months ago. We saw many people with acute low back pain that were seen very, very delayed in their journey. We would see people at anywhere from 6 months plus up to a couple of years. And we would track back to ask them what they had done for their acute low back pain management. And it was quite varied, some of the responses that we saw. In speaking to a number of family physician colleagues, emergency room physician colleagues, as well as spine surgeons, they were alluding to a very similar thing. Many patients weren't being managed properly in their acute period, and hence many of them transitioned into chronic low back pain, which we all know becomes disabling and costly and very challenging for patients and their families. So on came the evolution of this program. And what you'd see in front of you is basically our referral path that you would complete prior to sending the patient to the clinic. As you can see on the top here, the patient label and any details that you might seem helpful for any of the clinicians at Evidence Sport and Spine. When you refer your patient to our center, they'll be seeing an advanced practice physiotherapist. So briefly, an advanced practice physiotherapist has extra training, usually at the graduate level, in areas of diagnostic imaging, specific details around pharmacology, around differential diagnosis, in particular, screening for conditions involving red flags or serious spinal pathology, and various medical lab, basically coursework that would assist the clinician in really screening a patient day one to say, is this a musculoskeletal injury? Is it potentially not a musculoskeletal injury? And we need to refer them back to their primary care home for the medical expertise that they might require for the condition. And we really, we collaborate quite well with the primary care home in terms of communication, as we know that their expertise is very valuable in terms of the family doc and other clinical and other medical specialists in managing patients that are not necessarily appropriate for physiotherapy or rehab and require further medical intervention. Any objective or physical exam findings, imaging findings that you may find relevant can be placed here. This is a bit of a key section to know. So of course, we mentioned what advanced practice physiotherapy could look like for the patients in their first visit. And all patients will be seen within 1 to 3 business days. Because of acute low back pain, we understand from the literature, which I'll allude to shortly, that the timing of physiotherapy is very important. All initial assessments are $115 booked in such a way that we have provided information to the patient ahead of time, that we're able to be very efficient and precise on their first day. And you can see some of the other key information that patients may ask you when they're seeing in your office that we try to put on this sheet so that you know what to expect, the patient knows what to expect, and then there's sort of minimal surprises. The ideal patients that we'd like to see would be currently non-surgical patients. They may turn into surgical patients in time, but currently non-surgical. They may have neck or low back pain. They may have radicular findings or just axial spine pain. All of that would be included in patients that we would see in this clinic. And of course, they can be traumatic injuries or non-traumatic in nature. For this particular program, patients that require surgical consultation might be excluded from this program. We would gladly see them in our regular advanced practice physio programs, but for the acute program, getting people in ASAP, of course, they wouldn't be surgical at the time. And unfortunately, at our center, we typically don't see workers' compensation patients, but we have many colleagues in the community. Some of our colleagues at Momentum Health would be glad to see those patients for you. As you can see at the bottom of our referral pad, we do have 2 locations, our colleagues in the south, and then of course our center in the north. When we go back to this point here, patients would be seen within 1 to 3 business days. There is some literature that would suggest that this is very, very important. If we look at this systematic review here, published in 2019 in Archives, the researchers were looking at studies that evaluated the timing of physical therapy for acute low back pain, in particular on the outcome of health services utilization. When the literature was appraised and evaluated, the authors concluded that early physiotherapy, within about 30 days of that index visit for acute low back pain at your clinic, the outcome would be quite positive. That early PT compared to delayed PT reduced future healthcare or health services utilization in terms of cost, opioid use, as well as healthcare efficiency. Pointing to another study with a colleague of mine, Chad Cook from Duke University, their group examined not just patients with low back pain, but patients with musculoskeletal pain, in particular shoulder, neck, knee, or low back, so that any condition diagnosed in terms of an MSK pain-related case involving those particular regions of the body, what they found was that although the majority of patients had low back pain, that early physical therapy appeared to be associated with subsequent reductions in longer-term opioid use and lower intensity opioid use for all musculoskeletal pain regions. So we tend to think that opioid use tends to be linked to those with low back pain, but early physical therapy, not only some of the evidence pointing to reduced disability and long-term effects pertaining to time lost from work, etc., but also important factors these days, which link it to reduced opioid use and reduced health services utilization. There is some evidence to suggest that lower risk of going on to spine surgery or the need for other interventions such as injections as well. So when the patient comes in the acute period, as we mentioned, within 1 to 3 days, most patients don't need a significant amount of treatment in that first visit. Education, pain management, clear description of their diagnosis and prognosis and pathway are some of the key items that will be reviewed day 1, and importantly, getting them moving. So the appropriate tailored exercise prescription would be provided to the patient on that day. We use a program called PhysiTrack, which is a program that will allow us to organize exercises within a software program, email it to the patient, or we print them off for those that don't have access to computer or not computer savvy. But those that are computer savvy, we would email the exercise program to the patient, and they have videos and audio to show them exactly what to do at home. They would have been educated on the do's and don'ts in order to facilitate improvement and not aggravation of their symptoms. And then we can chat with them back and forth through a text function within the program so that they're always able to stay on the right pathway. If they have questions, if they have concerns about an exercise, they can text us right away. The information gets sent back with any corrections or modifications, and they keep themselves on the pathway towards improvement. And that program has been invaluable since we've implemented it. When we look at the initial exam, one of the final points that I want to leave you with here, I'm just going to switch screens, so pardon me for a moment, and taking a look at red flags. So red flags, although very rare in terms of those with acute low back pain of a serious spinal pathological nature, is quite rare. Anywhere from less than 1% to 2% of cases would this could be related to. If you look at this checklist here, we've gone through the literature and we've pulled out the key red flag findings. They can be demographic factors, such as age of onset. They could be physical exam factors, such as loss of anal sphincter tone or fecal incontinence, all the way to other medical factors, history of hypertension, history of arterial disease, and so forth. With the columns on the right referred to would be the potential serious pathology. And again, in our careers, we may see this a couple of times, but it's quite rare. Cancer, infection, spinal fracture, inflammatory disorder, Codd-Aquinas syndrome, AAA, etc. If the patient presented with any of the findings related to the gray boxes, this might raise a bit of concern, whereby if we felt that potentially the low back pain was coming from a non-MSK source, then we would communicate this back to the family physician or to the medical specialist. Again, we're not making a diagnosis of any of these conditions. That wouldn't be within our scope of practice, but it's within our scope of practice to identify that a patient's low back pain may not be MSK in nature, and that could be coming from another source. So we've made sure to go to the literature to identify those sources and potential clinical indicators of those issues related to serious spinal pathology. All of our advanced practice clinicians are well trained in this, and this checklist is essentially used behind the scenes on their initial visit to make sure that we're dealing with an MSK condition, which again is the majority of the time, and that we're moving forward with the appropriate management. So I want to thank you very much for your time. Please feel free to reach out to our clinic via email, via phone. I'm happy to discuss any further points that you might have or questions that you might have on the urgent back pain rehab and physio program, and who may be a candidate, and discuss any other questions you may have. Thank you again for your time, and have a great day.